the Custom Rule Building and AccelaSMART webinar. And Stuart Wiggins, this is Catherine Bayer, and Stuart Wiggins is going to be doing the presentation for you guys today. You are in a mute mode, and so if you have questions, we definitely want to answer those. If you'll look in the panel on the right-hand side, you will see a plus sign and questions, and you may click on that and send a question to me. It might say to Shelley because I'm signed in as her. She normally does this role. And so if you see that and need to have any questions answered, please do not hesitate to send those out. We will try to address them as we're going along or at the end of the session. And obviously, if there are any questions afterwards too that you think of later on today, please don't hesitate to reach out to us, and we'd be happy to answer those and get them back to you. So without further ado, I will pass the baton on to Stuart.
Thank you, Catherine. Good morning, everyone, and welcome. We're here today to discuss why it's a good idea to use your AccelaSMART rule building capacity and how to do it, and specifically with a focus toward those unspecified ICD-10 codes. So, there's good news and bad news this year, of course. And the good news is we survived October 1st of last year. Our stakeholders, for the most part, were all prepared. The claims process has been successful. Patient care did not suffer. And CMS agreed to delay the denials due to unspecified codes. Now, with that comes bad news. And the other side of that coin is CMS only agreed to delay denials due to unspecified codes to October 1st of 2016, this year. It was part of the sort of agreement to say, we'll extend it, 365 more days, but with that promise to extend the deadline comes this fact that we will delay denials due to unspecified codes, just move to ICD-10. So one thing that's happened with that is that there are some poor workflows that are working today. There are providers who may be using a laminated cheat sheet of their quick and easy diagnoses, and just to fit on there, they just chose the unspecified codes. They may be using a phone app to look up stuff, and the .0 code or a more unspecified code might be up at the top, and they're just choosing that one first. Or they may have a workflow in their EHR, and they're sending us diagnoses, and they're not being specific, just through lack of training, or just it might be easier for them that way, and that's what they chose to do. And those bad habits are being reinforced right now because we're getting reimbursed. We're in that delayed denial period for unspecified codes. Now, unfortunately, a lot of leadership focus has lost the laser beam attention that we've had on ICD-10 for all those many months leading up to that, and we've got to still think about the consequences coming up this fall. So, as I said, up until October 1st of this year, no claims will be denied for lack of specificity. No penalizing if you don't have specificity in your PQRS or VBM, or there'll be MACRA and other things, programs after that. And they only agreed that because they said we're not going to delay again. Our risk of unspecified codes in the short term are denied claims, an increased AR, because if it's denied, you've got to research and refile, that type of thing. And if you're having to ask your physicians for more specific information, it could be loss of productivity for them, certainly loss of productivity to our coders. And one thing to let you know, that October 1st deadline that's looming out in this year, there's some carriers that we're hearing anecdotally that are already saying that's not specific enough, we deny. And Georgia Medicaid is one of those carriers that has come out and said that's what they're doing. In the long term, there's always talk of future compensation models and always differences, but there's the idea that there'll be more value-based reimbursement, that we'll be facing flatter declining revenues, and risk-based models, some financial penalties attached to if you don't code the way they want, and HCC, the hierarchical condition categories, ACO, Medicare Advantage. I mean, there's all kind of alphabet soup of programs out there, but really what we know is there's a new bullet in their arsenal, and that is ICD-10 codes are much more specific and can allow much more specificity, and so carriers are likely to use that in their compensation models. and we want to make sure that we're positioned to get the best information to them. Now, when it comes to data on unspecified code use frequency, the national average that we're have access to right now is that people are coding about a third, not quite a third, of their codes that are going out are that unspecified category. Now, on the average, our white plume customers look like they're less than 11%. Now, your average, I don't know. A lot of the client account executives have been in contact with you and have run an unspecified diagnosis reporting list so that you can see, are your doctors being very specific and getting that information onto the ticket, or are they trying to choose stuff? And sometimes even if you're using our AccelaCapture tool to capture your charges, there is a way for doctors to manually enter their diagnoses, and some of them are using that laminated cheat sheet or some other little lookup tool to bypass all the logic you've put in to drive them down to a more specific scenario. So until you run your own analysis, you won't know where you fall along that spectrum. Now, the consequences of the unspecified codes on our workflow, the physicians touching it and billing, etc., they're giving it to billing. If you find through your research that they aren't using the right codes and having to send it back to them, that's delaying reimbursement because they're having to look at it, send it back in a circle. Certainly, we'd rather keep it at this strata than to let them get all the way to your practice management system and have to touch them again, or even worse, get to the clearinghouse and get bounced back, or the least desired consequence is it getting to the payer for denial or a delay or reduced payment. So it can impact our workflow. It can create great inefficiencies, our productivity loss, and delayed reimbursement. So you can just see that what we're going to try to work on is make sure that at least at the biller level we catch unspecified codes and return them to the physician for resolution if necessary, or maybe we're going to refer to the chart for more specific information. But we're going to try to make certain that it doesn't get past AccelaSMART to get out there. So now, how at risk is your practice? How do we get the right code the first time without turning the physicians into the coders? Well, there are a couple things. You can look at some revisions to your form design or to your custom scenarios. Now, that's going to be a topic for a different webinar or for one-on-one training, or you may have already focused on that. But you can sort of design your form to have different choices, your scenarios maybe to remove or to resequence and put those less specified codes elsewhere so they're not so tempting for the physician, or if you feel like they don't belong in the scenarios at all, they can be removed. Again, a topic for another day. And if you don't use AccelaCapture, our electronic charge ticket, and you get your charges into AccelaSMART via another vehicle, like passing from your EHR, then those two sources aren't as specific. Today, what we're going to focus on is how you can use custom validation rules to alert your users when an undesirable diagnosis is used, and how we can present them with better choices. Now, that's appropriate no matter how your charges are getting into AccelaSMART. So when it comes to our custom validation rules, here are a couple things that we could look at. If the doctor is choosing an M25-519 unspecified shoulder pain, well, that might be a form revision, because you can do those right and left little choices and they'd be able to just choose that on the form. But instead, if they're having to pop up this scenario and they're choosing an unspecified otitis media of an unspecified ear, well, then you can choose to edit your scenarios so that they can see them. But if they miss that, we want our edits to be able to tell us more specific, because it's not just whether it's otitis media, but is it acute, is it chronic, is it serous, is it suppurative, is it due to a perforation? There are all kind of choices that can be more specific than that H66.90. And here's another example with some different codes, and we're going to build a custom, or I think I already have built a custom edit for the hyperlipidemia code. Now notice, here's not the hyperlipidemia, but notice that the E55.9 vitamin D deficiency really only has that one code for it of vitamin D deficiency unspecified. So really the only other thing that kind of relates to vitamin D deficiency that isn't that is rickets. And so that's, you're not going to diagnose everybody that doesn't have enough vitamin D with rickets. So that may or may not be something that you would change on your form or that you change in your scenarios. That'd be up to you. But things here like where that might be on your form or might be what the physician's using, you've got more choices that you can use. Now there are dozens of codes that are more specific than M19.90, the unspecified osteoarthritis of unspecified site. So I didn't even show all those on the spreadsheet, but you know there's so many choices, and we'll talk about an alternative in our custom edit feedback that can quickly drive the coder to get all the choices, even though they might be more choices than would fit in your expanded text. So I've looked at my unspecified analysis. Now what am I going to do next? Well, work from the top down. If you've got that report in hand, and if not, I imagine you've already talked to your client account executive, and that's how you found out about the webinar, so you probably have the spreadsheet in hand. And you'll notice the most frequently used diagnoses are at the top of the report. Work from the top down, whittle down those big problems first, and look to see if there are any appropriate versus any inappropriate unspecified codes. There may be times that you ascertain that, you know what, it's called, quote, unspecified, but like that vitamin D deficiency, we're not going to change that to rickets. And so I'm not going to build an edit or change my form. So I'm going to skip down to the next one that would be an example that I would work on as an inappropriate unspecified code. And if you determine that certain codes are appropriate, you can fight your payers on those and say, this is why I think I'm coding the exact thing, even though the word unspecified might be in the description. But we certainly want to work to prevent and correct inappropriate instances. So we've already talked quite a bit about the E55.9 vitamin D. That could be an appropriate scenario, and we would let that stand as opposed to changing that or forcing the doctors to choose rickets. But some inappropriate examples, like my osteoarthritis, unspecified. Is it primary? Is it secondary? Is it post-traumatic? Is it with myelopathy? Is it with radiculopathy? So there could be, depending on how you count, 95 total ICD-10 codes for that. And if you're using 11% of your encounters with that unspecified code, not a good thing. So you need to specify your. So I've said not only would you need to check primary versus secondary, but also which joint, which laterality. Certainly those matter. So as we talked about, how appropriate is an unspecified diagnosis code from your report? On the spectrum of top to bottom, are they happening frequently? Are they happening only rarely? Are they never okay? Are they always okay? So the wisdom, I think, would be that we're going to work in the upper right quadrant. The things that are happening frequently that we know are never okay. But you may want to look down your list a little past high frequency to see if you see any high dollar procedures, because you'll want to work to mitigate quickly those reimbursement risks as well. So even though you might start with high frequency to low frequency, keep in mind the dollar consequences too. And I'm sure you're doing that, but I didn't want to overstate the obvious, but don't do the most infrequent one at the expense of something that could be higher dollar impact. So here on this ticket, this is an AccelaCapture ticket with hyperlipidemia at the bottom. And you'll see that you could have a scenario with just a couple of choices of other hyperlipidemia or the unspecified code. Or you could revise your scenarios to provide many more choices. So it kind of just depends on if you're going to use the gems, the thing out of the pocket, or kind of design your own. But also, you could have a rule that says this is an unspecified code that may cause a denial and explode to the more specific information, and you could have the choices that you want your provider to see. Now, this depends if you do validation at AccelaCapture, which some practices do. Their providers or a designated person within the clinic checks in each ticket against rules to see if there are any edits that violate. I'll admit that's a minority of people because of the speed of the workflow and the focus on the patient experience and the preserving providers' time. Not many people validate in AccelaCapture, but if they do, they need clear, concise feedback in order to work quickly to correct it. But more times, I would admit, it's in AccelaSMART, where the coders or billers are getting the consequence of this, but trying to make sure it gets no further down the revenue stream. One thing I'll point out, and we'll look at when we're actually interactive with custom rule building, is that we have remedy codes present. And if you've worked a lot with custom edits, you know what remedy codes are. They may be new to you. It's a pre-approved pick list that your consumer of the edit can get and highlight, and without having to type it out and perhaps skip a digit or transpose something, they will be able to click on the option and have it go into the diagnosis field. So this is how it would look in AccelaSMART. So you have your ticket that has the E78.5, and the edit says there's your unspecified code. See that where it says remedy codes available? That's how they would know. And there's the expanded text. And if they highlight this so it turns blue and clicks remedy codes, then they get the list there. Choose the one they want, because we had room to put the description there. Maybe it was mixed hyperlipidemia, and so they chose the E78.2. If they highlight that and click OK, it's going to give them a pop-up that says, do you want me to replace this one in the same coding family? If they say yes, then it's going to go there, and still diagnosis 2 would be linked to whatever that had been linked to. So you'd preserve all that. Now, when we're about to go into AccelaSMART Validation Rule Manager shortly, there are 3 or so ways to get to it. From within AccelaSMART, there's a menu bar at the top, Tools, and you can navigate to AccelaSMART Validation Rule Manager that way. I'm a fan of that because you can be in the batch, go to Tools, make some changes, come immediately back to your batch and test and know if your edit is performing as you wish. Otherwise, you might need to log out and log back in to see if your rule is cached and is working. So when you use the bridge or that little shortcut from within the application, you know that right away as you validate, you'll have access to that. Now you could also, depending on your operating system, go to Start, All Programs, White Plume, and then there's in that list of programs the AccelaSMART Validation Rule Manager. Or if you're somebody that navigates through your Windows Explorer, you right-click Start, Explore, go to the C Program Files, or depending on your operating system, it might be Program Files x82. Into the White Plume folder, and you'll see an executable for the AccelaSMART Validation Rule Manager. And if you're the kind that's going to use this super frequently, you might create a shortcut on your desktop so that you could get in and out of it for frequent rule maintenance. So let's go in and look at AccelaSMART Validation Rule Manager. Pull that up here. And I'm going to do what I said. I'm going to start with the shortcut from within AccelaSMART, choosing Tools, AccelaSMART Validation. Let me maximize that. And so there are 4 major categories of rules. The Unicore rules, that's the Alpha 2 rules that come every 3 months. You get an email from us that says there's coding content update, and within that you've got the LCD, NCD, CCI kind of rules. The static rules and the system rules are from White Plume. Within the static rules, think of these less about coding and more maybe content or formatting. There might be a way that if you're sending your charges into us via EHR, that somebody chose a code but the quantity wasn't they didn't choose a quantity of 1, and it's got to be greater than 0, so we get that. Or perhaps somebody is able to make an appointment in your appointment system and send it to White Plume, but not choose the location. And so we could recognize the absence of that and call that to your attention. So, or even make an appointment without a provider. Now there's another one here. Please look in the flag section on the encounter. So those of you that have been with us a really long time know that we used to be able to bubble in a spot on a scannable form and have people stop and read notes. In AccelaCapture, there's typed notes within the tabs, and physicians can type billing notes to alert the users. I would tell you that on any of these rules, you can change the text to have it say what you want to say. So instead of saying look in the flag section, you might want to say the user entered a manual entry note in AccelaCapture. Click the notebook icon to view the note, take appropriate action, research and add code, make adjustments as necessary, and when finished, click the codes added to prevent this edit from appearing when you revalidate. So you've got the power within this tool to give very specific feedback to your end users so they understand why they're being stopped and exactly what they need to do. So, and you could abbreviate this. You've got 80 some odd characters that you could put a subset of this in the brief text so that they would see that and understand this as well. I just left that on there so that would be familiar to you if you saw that. So you've got the static and system edits. Within system, you know, maybe your provider marked the procedures and diagnoses but didn't link them, and so that would be something that we could call to your attention. Or heaven forbid they marked their diagnoses but they didn't even choose a procedure before they marked it complete to send to you. So again, that's not quote unquote a coding problem, it's more of a formatting problem, but things that come out of the box with your White Plume rules. But when we focus on the rules for the unspecified, we're going to build those in the custom area. And we deliver 11 pre-built categories. You aren't required to use these subfolders. You can right-click and add new folders with your own names. It might be Barbara's Commandments or Blue Cross Rules or Surgery Edits or whatever you want. So in my White Plume demo, I have already worked on a rule for this unspecified code. So let's look at the details of this one. My brief text is, this is an unspecified code that may cause a denial. See below for more specific code alternatives. So when they expand that text, they would see the E78 and its description, the E78.1 and its description, along with the E78.2. And then the rule expression, this rule appears when they have the unspecified code. It's in your business entity. Here is my remedy code. So I clicked on the ellipsis to the right of that, and I get 3 categories of pre-approved lists that I could present for the user. In this case, I wanted diagnoses. And anytime you see this type of data entry tool in our system, think of this row at the top as the entry level, but it's not part of the list until you click Add. So if I had another code, E78.4, and I go to save this, see, I look and I see 5 codes right there, and I come back and look at it again, it's not there because I never added it, right? So be aware that you want that entry row to be empty when you save your work. I'm going to remove that because it's not valid. Just some points of reference. You'll probably always want to use your business entity. You may call it database, AR, partition, company. Your practice management system may have a different label for that line of business. We call it business entity. But choosing that, make sure you have the most robust list of codes in the variables when you're building your rules. If you've got 2 companies, Dr. 1 may not be the same provider in your code list as Dr. 1 in the second business entity. So we don't provide provider code when you're kind of up at that global level. because we're afraid that it might not be universal. So codes like provider, insurance, location that might be unique to a subset of a business entity aren't available to you. So that's what happens when you are more specific. Category is a free text field. It appears when you expand the ticket and can say whatever you want. And once you start using categories, you get a drop down of whatever's been used before, so it can have some continuity of that. And the warning, informational, and critical labels is just whether you get a blue, yellow, or red dot next to your edit in AccelaSMART. The red ones sort to the top, the yellow ones are in the middle, the blue ones are at the bottom, and you get an option to filter out. So maybe the least consequential ones, the informational ones, maybe only the ones when you're doing hyper audit alert and trying to pull some examples of certain things. You might hide the blue ones at the end of the month when you're trying to get all your charges out. So you've got the ability to sort of sort them by the severity, as well as you can display or hide by severity category. In this wizard, when I went to build this rule, I chose a category and I just filled in that the diagnosis is E78.5. I could go in and add other categories to this. This isn't meant to be specifically a how to use custom edits, but how to think about them in context of unspecified codes. So here's one way. I've got the text in the rule with the description. Now what I'm able to do too, since you've got that spreadsheet, let me open a spreadsheet and show you this. Oh, that's not it. So let's say that I needed to build a rule that had all of these. I'm going to click and shift click and pull in that range. So it's got the code and the description. I'm going to copy. And so now I'm going to paste. I'm not, because I did too many. Sorry, cannot exceed 512. Let me choose a smaller subset, which speaks to the fact that we need another tool. Copy. So that's nice that I didn't have to type iodine deficiency hypothyroidism and check my spelling. It's nice that I was able to pull that in. But for some of the codes that have such long lists, that's not going to be practical. It's not going to be practical, if I've got pneumonia, unspecified pneumonia, and there are all these other categories. I can't get the code in the description, even though I can have a remedy list that has all those J codes in there for the pneumonia categories. My user wouldn't know viral from streptococcus or from any of these other options. So we're going to have to think about a choice for those. So let me close this guy without saving those changes. And we're going to, still within this same folder, because rules are built in the folder that you have highlighted, 3 ways to have the rule builder pop up. File, new, rule. Or if I'm in the folder, click the fresh sheet of paper, you see the little tooltip that says new rule. Or from down here, right click, new rule. And I've got the ability to say, highlight. Wouldn't you like the world to be watching you type and feel like you had to be perfect? Okay, highlight diagnosis. Right click. ICD-10 options. And I'll just cut and paste that here. And so, for instance, if I had something like the pneumonia code, the J18.9, and it breaks down to all these different categories, I don't have room in my expanded text to have all this extra text show up with all these choices. Even though my remedy codes would hold a list that long, I don't have that. So I'm going to need to put that in my business entity. Yeah. I could put all the remedy codes here if I choose. I'm going to say in a diagnosis requirement when the diagnosis is J18.9, J18. So down here in the entry field. And that's all I want. I mean, if I wanted to exclude certain insurance carriers because they're not using or they're not penalizing yet or whatever, I can add variables, but really that's all I need in my message so far, because if I click next, I've got all the different choices of categories, properties that I can add. But I'm really finished. Finish. And when I click enable, I always look across in the bottom right to make sure I see the word successful, and then as I cross, I look across this message field to make sure that there is no error message that appears, because it will not save your enabled checkbox if this is not successful. And that happens sometimes when you come in here and you're like, oh, did I mean to do a 9? Oh yeah, I didn't mean to do a 9. And you deleted that and you come back because you're just editing in this, and then when you try to enable it, you get a failed and a message parsing. And I just had to learn that parsing means that half of something is missing. And so I'll put that in there. And it's all good, so it's successful. So knowing that I've built rules looking for those unspecified codes, the problems that I've identified using my spreadsheet, I can go into AccelaSMART, and here I have a ticket that has both the E78.5 and the J18.9. I could revalidate all 10 of my tickets, but I've already validated one, so I'm just going to validate this one ticket. And so I have this message for the E78.5. Unspecified code may cause a denial. That's why I'm being stopped. See below for more specific code alternatives. Manually change the list to the appropriate code or select from the remedy list. So I can highlight, choose the remedy list, and I want mixed. And I click OK, oh, except for that. Do you wish to replace the code? And when I click yes, it changed it. So if I were to revalidate now, that message has gone away. Now I have a different message for my J18. My most specific diagnosis code was not used. Highlight the diagnosis at the top of the encounter, right-click for ICD-10 option. And is it adenoviral? Is it due to staph? Is it unspecified bacterial? I've got all these choices, so I can choose that, and I need to change my label, but yes. So now I have this, and so when I validate, I'm fine. Now I still have a diagnosis for an ingrown nail that I've not chosen to do any procedure to solve it, so that would be another edit to look at the chart and figure out. But so I've got, I've built those rules a couple different ways to highlight for my billers and coders that the presence of an unspecified diagnosis is there, and I've given them options on how to clearly and accurately change it to the more specified code. So back to my some helpful hints. I would remind you to be very specific in your edit message, telling your user precisely why they're being stopped and exactly the action you want to take, just because for some of them it's new territory and you want to be clear and you've got enough room in that 500 some odd characters to tell them exactly what to do. You want that user to understand that, why and what to do. Consider using the remedy list when appropriate to present a pre-approved list so they don't have to type them in. If you want your rules or filters to apply immediately upon the next validation click, you're going to access AccelaSMART from within AccelaSMART Validation Rule Manager from within AccelaSMART. Now, if you built a rule that's so brilliant and so important that right away you want all 15 users to have it at the very next time they push validation, and they didn't use the bridge to get there, so it's not cached into their rule thing, you may want to tell them to log out and log in to make sure they have that rule immediately. Otherwise, it might take up to, I don't know, 20 or 30 minutes for the network, and it's passing around to check to make sure that everybody has the most current stuff cached, has the newest rules. So it gets to them anyway if they stay logged in all the time and never log out, and it gets to them whenever they log in. So that says all that. I wanted to remind you there is a user guide for the AccelaSMART validation. If you go to Start All Programs White Plume, there's a subfolder called User Guides with the AccelaSMART validation topic covered. There's also online help within the application. So if you're in the Validation Rule Manager and you click the Help button, there are topics to look that up. The distinction between the user guide and online help won't have illustrations or screenshots. Because you're in the application, you can see the pictures there in front of you. User guide you may take and read at home if you having trouble with insomnia, or you're just somebody who likes to study and highlight and make your own notes. It will have illustrations where the online help does not. When you're building your rule, some of you may grow bold and feel like you don't have to use the wizard to type in the expression that says this is when the rule is going to fire. And even though the expressions sound like a math word problem, and you're saying things like greater than or equal to or whatever, you can't use the symbols. You have to use the text. So you'd use the word equal versus an equal sign, or you'd use the word greater than as opposed to the right-facing little arrow. The system will determine if you're using actual codes or generic codes. So typically, if you're using generic codes, you don't have to worry about that in your verbiage. And if you're have geriatric or pediatric patients, and so some of your rules are age-specific, it can sometimes throw you off that the variable is called date of birth, but you can use that for patient age. So if you say when date of birth is between 2 and 10 years, it sees the word years and knows to calculate for age. It's taking the date of service, it's taking their date of birth, and it's calculating the time between those. When it comes to negative conditions, this is less of a level 100 class and more of a 400. There are two different ways to use a negative condition that each has different results. So I'm more planting a seed in your mind rather than you'll walk away and immediately know with clarity when to use which one. But I just want to point out that when you say is not, it ignores if there's a blank. And so when you say the provider is not Dr. Smith, if it's blank, it's going to ignore that. It's only going to be when it's somebody else. It has the potential to fire multiple times if you say when the modifier is not RT, and you've got a right and a 59, or you've got, if you say the diagnosis is not diabetes, and you've got diabetes and obesity and shortness of breath, it could fire for the shortness of breath and the obesity because those are not diabetes. So you could have multiple rules even though you didn't expect them. And grammar of the words is not always comes after the noun, so the diagnosis is not. And the information after the word not is a long list. They must be joined by the word and. Your logic may think, oh, this really is an or, and I get that, but it's just an idiosyncrasy of this particular grammar situation in the program. The alternative is to say when no diagnosis is. It pays attention to blanks, and so if there's no diagnosis at all, it would say, none of them are diabetes. I need to know about this. It only fires once. In grammar, the word no comes before the noun you care about, and it can have an and or an or list. It doesn't have that same constraint as an is not list. So that may be a little bit more detail than you want, but if something's not behaving the way you expect, it might be due to the use of one versus the other. I think the takeaways we want to take away from today are, why are we still talking about ICD-10? Well, don't think that ICD-10 ended on October 1st, 2015. It came and went, that's done. That's the day it started. It started on that day, and it is with us now into the conceivable future. So that's why we're still talking about it. Short-term and long-term risks, we recognize that coming up, there's now a weapon in the insurance carrier's arsenal that they can penalize for use of unspecified codes. And so we've got denial risks. How do I use my unspecified analysis? So you've got that spreadsheet, know your most frequently used codes, and work from the top down or from the top dollar down. And how are you going to prevent and correct those unspecified codes? Certainly, if you're using AccelaCapture, you could revise your form to offer better users, and some of that might be better choices for your users. Some of that might be form design. Some of that might be how you design your custom scenarios that pop up from the form. And then certainly custom rules was our focus today, that if you identify the presence of an unspecified diagnosis, well then you can provide feedback in your edit, either through the expanded text or through instructions to look at the scenario by right-clicking on the diagnosis, and get a more specific list before you send it to the practice management system, before it goes out on the claim to the carrier. Now, I would be, if you don't have the time or the inclination to build your own rules, we do offer a program where we can do some of them for you. And so typically, for most people, they kind of focus on the top 10 rules, and we would build custom scenarios based on those and build the appropriate edit or custom rule based on that, and either include the specified ICD-10 codes in the expanded section where they fit, or what we saw in our illustration today, instructions to reference the ICD-10 scenario list. And we would actually log into your system and deploy those for you. So that cost, if you want to delegate or contract us to do that work for you, that would be a $2,000. Your client account executive can help you with that. Or if you don't remember who they are, you can just call support and say, on that webinar they talked about getting help on building unspecified edits. I want more information about that, and they will get with you. At this point, Catherine, have we received any questions or comments or things that would benefit from some clarity or review?
I do not have any questions at this time. If you guys have any, we'll give just a moment for you to type those in if there are things that you have that you need to answer now. And as I had mentioned earlier, if there are things that you think of later on in the day, please don't hesitate to reach out to support, and we will get those addressed.
We appreciate your time and attention today, and I hope you're looking forward to using the tools at hand to provide even more specificity in capturing your diagnoses as they go out to the carriers for their ICD-10 ultimate level of accuracy. Thank you for your time and attention today. We'll hang on just a minute to see if any questions pop up. Otherwise, enjoy your day and be productive. Look at chat. All right, everyone. Thank you for your time today. Appreciate it.